That's the topic for today, Dr. Scott. It's all yours.
So it's January and we're all tired and we're sick of COVID. So I thought we'd just do some fun little short topics. Connor, that was a great case. It's really fun to have a case to talk about. And that was a really good one. So I don't know about all of you, but in January, I think I better get going on my exercise. So go ahead, Sneha, can mine? So I wanted to, so I was looking around at a few kind of the recent topics and some of the recent research, and I just picked up a few things that I thought we could discuss. So I thought this was sort of an interesting one. Does anyone remember about 10 years ago when minimalist footwear became really common and everybody wanted to go to barefoot running? And it was actually, it worked well for some people, and for other people, they had all kinds of problems doing it. So it sort of fell out of favor. But there were some research and some things done. And this woman, this Irene Davis, she was really the person who pushed it the most and was very interested in it. And she came back with a recent article now talking about not just athletes who are doing marathons and ultra, but she's talking about seniors and children and what kind of footwear we should have them in. And I might point out that I wish this C. Scott was me in this article, but it's not. So this woman's at Harvard Medical School, and again, she started the minimalist or the barefoot running trend. It was popular about 12 years ago, and it was sort of controversial. Some people went right out and went from a great big padded shoe and started running barefoot and did have some injuries. But the studies really weren't all that clear. It probably didn't greatly decrease injuries, but maybe it didn't increase injuries either. Some people did really well with it, and some people didn't, depending again, I think, on how you run, maybe your body style, how fast you went over to it. So it's one of those things that some people have continued, but it sort of fell out of favor. And then we went to these mega cushion shoes, like you've all seen the shoes with the great big thick soles, like Hoka's and stuff like that. So go ahead, Sneha. They started doing, again, there's not a lot of hard research on this, but they started doing some other studies with kids and seniors. And what this little article came out and said, maybe if we put children in shoes that are too rigid, braced, too cushioned, we don't allow their foot to develop normally. And I would say the exception to that is certainly in children who have orthopedic problems that really do need to be in some kind of a treatment. Again, they just thought, well, if we put them in shoes that are too tight, too small, too heavy, it might lead to future problems. They're in the process of doing this research. So again, not a lot of hard and fast. Now in runners who successfully went to minimalist footwear, some people who had big problems with things like shin splints, etc., have done really well. And I've changed some of my patients over. But again, it doesn't work for everyone. So if you have a 250-pound big male runner that you try to put in a barefoot shoe and say, go out and run 5 miles, it's going to be a problem. So they have to go over slowly. But when they do look at the studies, it looks like there is maybe something to the minimalist footwear, or at least getting people barefoot a little bit more if it's in a safe place. So this was, I thought, an interesting, and again, this is in process, the study, but they looked at seniors, and seniors that got in the really cushioned shoes or the really high shoes. They thought that perhaps that could filter out the sensory clues and it might diminish their balance and stability. So when I was a kid, my grandma wore Keds, and Keds had nothing but a little piece of rubber on the bottom. And I think, wow, maybe she was ahead of her time. Now, again, take this with a grain of salt, because some people might need specific footwear, diabetes, they need a heel lift, a rocker sole, a narrow shoe, a wide sole. But the bottom line is that you can consider minimalist footwear, even in children, seniors, and people in the middle if they're having certain problems. If you want to consider it, and it's particularly someone who's a runner or going to be exercising, they really need to go over to that minimalist shoe slowly, because the minimalist shoe tends to have no heel lift to it. It's flat. And you know, if I'm like this in a shoe, the reason women have trouble when they wear high heels all the time, Neil probably treats these. They get an Achilles tendonitis when they retire and they don't wear heels anymore. It stretches that Achilles tendon and your calf muscles. So if you go from wearing a shoe with a pretty good heel and all of a sudden you go run 5 miles in a minimalist or totally flat shoe, it hurts based on experience. But anyway, it's just another option. If you're having people who are having a lot of problems, sometimes some of the patellofemoral, the shin splints, those type of things, it may be an option. You may just want to look at your seniors and watch them walk and see how are they doing. Are their shoes maybe too clunky and thick? Can you trade them to something else? And then children too. You know, again, research is coming. They're doing the research on it, but it was brand new out, and I thought it would just be interesting to discuss.
Go ahead, Dr. Dalton.
Yeah, so Dr. Scott, I just was wondering if you had a blanket statement on arch supports or no arch supports. I know when I was a teen, it was like, oh, everybody needs arch supports. It sounds like with this minimalist, not so much.
Yeah, not so much. So when I was doing sports medicine, I had a fair amount of football players who were of like Southern Pacific, maybe Samoan, Tongan, and structurally they had really flat feet, and they would come in and we put them in an orthotic and they'd have terrible foot pain. So it sort of depends on what the foot is and what they're trying to do with it. So I wouldn't say blanket arch supports. I do try to get folks who are having particularly shin splint problems, Achilles, I do try to get them to walk around barefoot a little bit more. We know it strengthens the foot. But I end up sending some people for orthotics. Again, it's just, these are going to sort of be on an individual basis. So I wouldn't say blanket one way or another. They're having a lot of heel pain. Sometimes I say maybe get some gel insoles, not necessarily support. So some people really like the thick supportive shoes and some like the minimalist shoes. This just lets you have another option as far as folks who are having, particularly the athletes or walkers who may be having some problems with the lower leg, some of those overuse syndromes. Okay, the reason I put this in is because, and Sneha, we can't go to the website, can we? Probably don't.
This website,
No.
Dr. Scott?
Yeah, would it let us go to it? The reason I liked it is because I'm always talking to my patients about, would you at least walk? And then they're like, well, how do I do it? What do I do? What should I use? How far should I go? And I have like 7-page handouts, and I know they never look at those. But this handout is a nice little 2-page handout that really, I actually looked at it and thought, hey, I might start a walking program. So when I look at something like that, I think it was simple, it was easy to read, it was easy to understand. Walking's a great, cheap exercise. You know, you might want to add a pedometer for a while. Again, those are cheap and simple and easy. And it may be a way that you can get people exercising rather than going into the COVID-filled gym with your mask right now. So I thought this was nice. I gave you some of the recommendations: walking at a brisk pace most days of the week for 30 minutes or more. You know, you can even do that at lunch, even if it's one of you that wants to take that on. But like I said, I really liked the little brochure. And so I put that in there mostly so you could go look at it and use it for your patients if you're trying to encourage them to get a little bit more active without the, gee, get a whole gym membership and go crazy on the treadmill.
I can try to open it. I have to stop.
It's okay. It's okay. They can. I should have probably. Well, it was too hard to try to cut and paste it in. But anyway, it's a nice It's a nice little, I thought it was a nice little handout for patients because it's easy to read. It's only 2 pages. So then I thought, well, if we're going to ask people to walk, are there some benefits? And there's lots and lots and lots of studies. And so again, this was just a little potpourri of research studies. So I put a bunch of little things in here. So you can say it actually decreases your risk of dementia. And that was 1 or 2 miles a day. So that's, in your at least half hour, maybe you'll get 2 miles in half an hour. It looks like you live longer. The AARP did a diet and health study. Some of these may be people who walk, may have other positive health activities that they do. So it might not be just walking, but it looks like overall people who walk live longer. They have less knee pain. And this is a good one. Walking for 40 to 60 minutes, 3 to 5 times a week, decreased knee pain by 30%. And so that's a good one. It may be that they lose a little weight with that too, and that can help decrease knee pain as well. Improved mood, and it's even been shown to be valuable for treating mild depression. You could certainly add it on to people with moderate to severe depression and may be helpful.
Dr. Scott, this is David. Yeah. What motivational speech do you give the patients who say, oh, it hurts to walk? Because I know I hear that, and if Lauren hasn't heard that, she will.
Yeah, when I take it, every patient's individual, and I will do sort of what Dr. Albertson talked about last time. Well, what could you do? Might you consider this? It's going to hurt at first. It's not. Sometimes patients think that they're hurting something. They're going to actually do more damage to their joint. And so they often ask me if it hurts a little when I start doing it. Again, it's going to be on an individual basis. If it's somebody who's got a bucket handle meniscus tear, I don't want them walking on it. But in general, what would you do? And I oftentimes see if they could find someone that would do it with them. And again, that's easier said than done, particularly with people who are younger and working, but, or a retiree who might be lonely. So again, easier said than done, but I'll try to say, well, what kind of things could you do, or how could we get this to happen? And it might hurt a little bit at first, but try it for 2 to 3 weeks. Try to do it a few times a week, and then come back and see me or call me, and let's see how you're feeling. So it's hard. It's hard to get people going, and I get a lot of people that start, and then when they come back 6 months later, they aren't doing it. But at least you can try. And like I said, it's cheap and it's easy and it's outside. So it's one of those things that's really pertinent for time right now. So you can tell them it lowers the risk of cancer. It reduces the risk of heart disease. I put the knee pain in there again. And it either decreases your risk of diabetes or helps with diabetes. And you're always trying to get people with diabetes to work out a little bit more. So it can be social. So again, if you're talking about somebody who may be a little older or lonely, if they can walk and get out, that's great. You can use the pedometer. Many people have watches that'll tell them how many steps they've taken in a day. And after I read this, I'm really looking at my pedometer every day and saying, geez, did I get above 5,000 today? I better get going. So it's even helping me, but you can go for a goal of 7,500 to 10,000 for a person who doesn't have a lot of orthopedic disabilities. If you're on a treadmill, you happen to be on a treadmill, just increasing the incline by a little tiny bit is helpful. You may have them walk a little faster, vary the terrain. These are for folks who've already been walking and want to sort of ramp it up a little bit. And then I tell them, well, we spent all this time evolving so we could get up and walk. You might as well honor your cavemen and cavewomen forebears and get out there. So there are a lot of benefits to walking. Again, it was one of those things that I thought everybody could do at this point, especially if you don't want to be in the gym with a mask on, and that little handout was really nice. So I thought I'd put that out for you.
Looks like Neil has a question.
Neil?
Thanks, Neha. I didn't have a question. I had just a comment, and for us down here, we have a lot of seniors that no matter what, if they might have COPD, they might be an O2, they'll make it to the casino. And so before, when I used to just discourage that, I evolved to say, well, if the casino is somewhere you want to be, take a lap, go find a different machine if you're not winning at one. And that seems to help some of them. And some of them have come back and said, it seems like I can walk on the casino floor, but I can't walk on the concrete sidewalk. And I don't know if that has any real bearing on carpeting or anything like that, but that's helped to get some of our older folks out.
Well, that's a great idea for us here, and that's a great idea for down there too. I think it is easier to walk across a casino floor than a sidewalk. I can't look down though because the carpet makes me dizzy, but I think that's a great idea, Neil. And it does get them out, and it's a social activity, and that's good for their brain and everything else too. So that's great. Okay. I thought this was really interesting. I started to read it thinking, okay, this is going to be a physiologic problem here, and I found that the study showed something different. So I do think that this is true based on patients who come in and will tell me there are certain times that they really have trouble and their exercise performance is impaired. And this one looked at particularly the mid-luteal phase of the menstrual cycle. And their hypothesis was that aerobic exercise performance is impaired in the mid-luteal compared with the mid-follicular phase of the menstrual cycle. So see how you go to the next slide and we'll find out what that is. Okay, so there's lots of research out there on things that happen to women during the menstrual cycle, whether, there's studies on do you tear your ACL more commonly, et cetera, et cetera, et cetera. So it's an area that's really that people are interested in, particularly high performing women notice it when their time is off by maybe a few seconds or something I would never notice in a million years. The luteal phase is a time between ovulation and before the start of menstruation. The progesterone goes up, peaks, and goes back down. And that increased progesterone will increase your core body temperature, increases your minute ventilation, increases your heart rate at rest and during exercise. And then interestingly enough, it causes negative mood states. I've never heard of that before. Okay, that's PMS too. So they did this study and they looked at these physically active young women, and they were definitely slower during the mid-luteal phase and the mid-follicular phase. The perceived fatigue was higher, the mean power output was significantly lower. They couldn't find any physiologic factors that explained the slower time. And so they attributed that it was the hormonal difference affecting the psychological factor, or the negative mood state, the effect of hormones on the brain. And I think that's probably true. So I thought that was interesting because when women come in and talk about PMS, it may be affecting a relationship, a job, something else. It can also affect sports performance and physical performance. So it's one of those things where when you actually talk to someone who really has trouble with, and I'll say PMS, premenstrual dysphoric syndrome, it can be really significant for them, and not just how their mood is, but really some of our athletes will notice that too. So I thought that was interesting that somebody finally did a study that said it's probably the mental effect of the progesterone rather than the physiologic effect on performance. So if you're going to the Olympics, you really hope you're not in the mid-luteal phase when your race comes up. So I thought that was kind of a little fun and interesting study. Anyone have any comments on that?
I just wonder how well those Olympic women do cycle, because we hear about that female triad in the youth. So I haven't been around any high performance athletes to further ask that question. But, yeah.
I was a athlete throughout most of my schooling, and most of the girls I ran with had no cycles, so that pretty much solves their problem.
And Lauren, was that because of being the athlete, or were they also like on a birth control to help not have cycles?
Nope, most of it was just amenorrhea secondary to, athleticism, working out so much.
Okay.
Yeah, and that when they're, I mean, that's an energy, probably, so, the hypothalamus says, hey, this body probably couldn't support pregnancy, so we're going to shut this down. But oftentimes they'll not only be over exercising, but restricting calories, and that can be detrimental to performance too. So when we have folks with the female athlete triad, one of the markers we use is, can we get you just to eat enough calories to get your menstrual cycle back? But then we might cause them problems with their mid-luteal phase performance. And sometimes we'll put them on birth control pills too, to just help with the, well, they can still get pregnant even though they're not having menstrual cycles. So someone will be on that. So it's complicated. We could do probably 2 hours on the female athlete triad too. Do we have another one? Oh, yes. Does everyone know Dr. Schwank, the former dean of the medical school? So he was the dean for our school up here for UNR Med, and he just retired in December. And I saw that he'd put out a little, I haven't even talked to him about this because I haven't seen him, but he put out a little blurb in Journal Watch, which is sort of something that just goes around and collates research studies out of various journals. And then you write it up for people in sort of a snippet. So he went around and looked at all the big studies and wrote it up. And he was talking about PRP injections for musculoskeletal conditions. They're still popular. Many people use them. Lots of anecdotal evidence that they work. Some studies that they do, some studies that they don't. And it maybe there's probably a lot of different reasons that it's still not exactly clear, but Dr. Schwank wrote evidence against PRP injections for musculoskeletal conditions. And he starts out and says the use of PRP continues to increase despite negative results. So just in general, if you're not clear on what PRP or platelet-rich plasma injections are, there are a number of different ways. Different companies have different ways to actually obtain this. And typically you take out the patient's, some blood from the patient, centrifuge it down. And again, you'll see you've got a number of different forms that this can come out as. Some of them are more amenable to being a topical product because they have a lot of fiber and you can't really inject a great big clump in. Some of them are able for injections, but that's the idea, is the platelet-rich plasma. They remove the white blood cells and the fibrin, and then you inject it back into the joint or the muscle or the area that hurts. It's also used sometimes during surgery. For example, rotator cuff repair. There may be a study where we did this person's rotator. These 100 people had a rotator cuff repair without PRP. These 100 people got PRP put in during surgery. So lots of studies out there. And part of the problem is lots of different products and different companies. So it can be a little bit confusing comparing these things. Go ahead, Sneha. So he looked at for his little Journal Watch, he looked at 3 rigorous randomized trials. So when he looked at these studies, he thought to himself, these studies were well done. And the first one is chronic mid-portion Achilles tendinopathy. So not down at the assertion, not clear up into the calf, but in the mid portion. 240 patients, they failed the usual care. I sent them to Neil, he sent them back to me and said, they're just not getting better, try something else. Just kidding, Neil. So they did PRP versus sham injection, And they looked at them at 2 weeks, 3 months, and 6 months. More patients had pain at the injection site with PRP versus sham, but they didn't have any difference in pain and function. So go ahead, Sneha, to the second study.
Neil might be able to fix him now with the casino therapy he told us about. So we should redo the studies.
Personally, the physical therapists mostly fix them all. I don't do PRP for it. I say go over to physical therapy and they can do their heavy, long, slow, hard, painful. Neil knows all those things. And most of mine get better with physical therapy. So Achilles tendon, I find it really hard for people to do a home program. I almost always send those for physical therapy. Anyway, back to the next study. The next study was moderate to severe ankle osteoarthritis. 100 patients. You either got PRP or you got saline into the tibio-talar joint. At 26 weeks, both groups were the same. We have one more, I think. Medial compartment knee osteoarthritis. Knee osteoarthritis is so common. Really would love to have the magic bullet for this. So almost 300 patients. They got weekly injections for 3 weeks. At 12 months, both groups improved by the exact same amount. Both groups had similar medial compartment cartilage volume on MRI, so it didn't help improve the cartilage either. So does he have a conclusion slide there, Sneha? So use of PRP has grown significantly in recent years. It's being used across lots of different medical specialties now. Again, the studies are variable quality because there's lots of different protocols. There's lots of different types of PRP. There's lots of different ways to actually make your PRP, depending on the company you're using. This one right here, it's expensive and it's oftentimes not covered by insurance. So it can be a significant out-of-pocket cost for patients. A few years ago, I had a nurse, she decided to try it. Every injection she had was $1,500 out of pocket. Nope. Well, does anyone have any questions about PRP?
This is David. So in my realm as a DO, we have this model called the fascial distortion model. And it was interesting hearing one of the people present on it. He said, you're essentially injecting a bruise into whatever you're trying to take care of. And so in the fascial distortion model, some of their techniques are similar to what most people know as like deep tissue massage or things like that. So he's like, essentially, we're just causing that same bruise with their hands. So I thought that was really interesting, but I do a lot of manual therapies and what I get to do. And so I'll mix this in there.
I like the manual therapy and the dry needling techniques. Some of those kind of things are, that may be it. I remember one of the first studies for tennis elbow, they just either dry needled or did PRP, and those came out about the same too. So that may be part of it. It's really expensive though, and insurance companies are increasingly not covering it until we have some good studies that say it really works. So I think if you're doing it, just pick your patients carefully. You don't want to do something just because it might be a good income. Okay, this was the last one. Who has a dog?
I fought it for years, but my kids finally won anyway.
Yay, well, here's a study for you. So higher youth physical activity is associated with favorable health outcomes, right? If we keep kids active, they do better throughout their whole life. The physical activity guidelines for Americans recommend that youth, the school-age children, should get at least an hour of activity daily, but this is concerning that only 1 in 3 kids even meet. So 2/3 of kids don't get that much, just an hour. So they did they looked at 9 studies that compared physical activity among youths with and without dogs. And almost 80% said there was a positive association between dog ownership and physical activity. So this conclusion, this is a brand new study, hot off the press. Dog ownership is associated with increased use of physical activity. Of course, you have to get them out there to do it and feed them and work with them and play with them. But I thought it was just a cute little study to talk about dog ownership. So David, that was you that said you lost?
Yep. I like my freedom to be able to be like, hey, let's leave for the weekend. But they're like, no, we want dogs. And then I'm like, all right, well, you guys had better be feeding and cleaning and all that. So it's taken a lot of threat since then to be like, all right, we're getting rid of the dogs if I step on poop one more time.
Uh-oh.
You know?
Well, I mean, picking up poop wasn't particularly, you know, it is a physical activity.
It
You're
is. It's more
outside.
fit.
You're outside.
They're outside. Right. Yeah. I'm having a problem with my teenagers wanting to be behind a screen.
Yeah, that's really common here too. And getting them out and looking up. I'm constantly telling people that humans weren't meant to be sitting like this all day long when they come in with their upper back and shoulder and neck pain. Yeah, that's pretty common. So I just thought this was, again, kind of a cute little study. That's all I think I have, right, Sneha? Oh, those are mine.
Okay, thank you so much, Dr. Scott. That was great presentation. Something different, but something very interesting. I enjoyed it. Thank you so much. Any questions for Dr. Scott? Or anything that you would like to comment, or any experiences you've had?
Hi, this is Don. I had problems unmuting and everything. Sorry about that. With PRP, I used to do those for rotator cuffs and we stopped doing those. But I found it real helpful to do a microfracture into the bone where the tendon's going into the greater tuberosity to stimulate bone healing, which is kind of like dry needling. More recently, dry needling's had a lot of success with lateral epicondylitis. I had a lot of success with PRP, but those are people that have had lateral epicondylitis for years. And I just don't like that surgery and didn't like performing it because I didn't like the results. But therapy is the key, doing eccentric muscle exercises and stretching. The biggest thing I found helpful for PRP was I had a couple patients with a distal biceps partial tear at the radial greater bicipital tuberosity. And the surgery for that is taking the whole tendon off the bone and then drilling a hole into the bone and then reattaching it, which is pretty big surgery on the elbow. And I've had two patients where I did PRP under ultrasound right into the tendinous bone interface. And both of them did excellent. One was a UPS guy, and I saw him a couple years later delivering packages. He said he never had surgery, loved his result, and was quite happy with his result. So PRP is not horrible in that instance.
Yeah,
That's been my anecdotal experience.
Yeah, there's a lot of anecdotal stuff out there and that don't have studies, and there probably is a place for it. It's just that we need to get some better studies, and there's some studies that have shown, hey, it really doesn't help in this situation. So we need to get a little bit better about standardizing the protocol, standardizing the product, and then being able to do the studies. So there may be places for it that we don't know about yet.